Hello, welcome to AI Medical School. In this video we are going to discuss the most common case, which is chest pain. But before the start, please subscribe to the channel. When you subscribe to the channel I get motivation and make more videos for you. So, this video contains 1. History 2. Examination 3. Investigation 4. Questions and answers and 5. Key points. Let's start with history. A 34-year-old male accountant comes to the emergency department with acute chest pain. There is a previous history of occasional stabbing chest pain for 2 years. The current pain had come on 4 hours earlier at 8 p.m. and has been persistent since then. It is central in position, with some radiation to both sides of the chest. It is not associated with shortness of breath or palpitations. The pain is relieved by sitting up and leaning forward. 2 paracetamol tablets taken earlier at 9 p.m. did not make any difference to the pain. The previous chest pain had been occasional, lasting a second or two at a time, and with no particular precipitating factors. It has usually been on the left side of the chest, although the position had varied. 2 weeks previously he had an upper respiratory tract infection which lasted 4 days. This consisted of a sore throat, blocked nose, sneezing and a cough. His wife and 2 children were ill at the same time with similar symptoms but have been well since then. He has a history of migraine. In the family history, his father had a myocardial infarction at the age of 51 years and was found to have a marginally high cholesterol level. His mother and 2 sisters, aged 36 and 38 years, are well. After his father's infarct, he had his lipids measured. The cholesterol was 5.1 mole per liter, the desirable range of 5.5 mole per liter. He is a non-smoker who drinks 15 units of alcohol per week. Now the part 2. Examination. His pulse rate is 75 per minute, blood pressure 124/78 mmHg. His temperature is 37.8 degrees centigrade. There is nothing abnormal to find in the cardiovascular and respiratory systems. Now part 3. Investigation. A chest X-ray is normal. The hemoglobin and white cell count are normal. The creatine kinase level is slightly raised. Other biochemical tests are normal. This is the ECG of the patient. You can pause the video to investigate it. Now the questions are, what is the diagnosis, and should thrombolysis be given? If you know the answers, let me know in the comment box. The answers are: the previous chest pains lasting a second or 2 are unlikely to be of any real significance. Cardiac pain, and virtually any other significant pain, lasts longer than this, and stabbing momentary left-sided chest pains are quite common. The positive family history increases the risk of ischemic heart disease, but there are no other risk factors evident from the history and examination. The relief from sitting up and leaning forward is typical of pain originating in the pericardium. The ECG shows elevation of the street segment which is concave upwards, typical of pericarditis and unlike the upward convexity found in the street elevation after myocardial infarction. The story of an upper respiratory tract infection shortly before suggests that this may well have a viral etiology. The viruses commonly involved in pericarditis are Coxsackie B viruses. The absence of a pericardial rub does not rule out pericarditis. Rubs often vary in intensity and may not always be audible. If this diagnosis was suspected, it is often worth listening again on a number of occasions for the rub. Pericarditis often involves some adjacent myocardial inflammation, and this could explain the rise in creatine kinase. Pericarditis may occur as a complication of myocardial infarction, but this tends to occur a day or more later, either inflammation as a direct result of the death of the underlying heart muscle or as a later immunological effect, Dressler's syndrome. Pericarditis also occurs as part of various connective tissue disorders, arteritides, tuberculosis and involvement from other local infections or tumors. Myocardial infarction is not common at the age of 34 years, but it certainly occurs. Other causes of chest pain, such as esophageal pain or musculoskeletal pain, are not suggested by the history and investigations. Thrombolysis in the presence of pericarditis carries a slight risk of bleeding into the pericardial space, which could produce cardiac tamponade. This arises when a fluid, an effusion, blood, or pus, in the pericardial space compresses the heart, producing a paradoxical pulse with pressure dropping on inspiration, jugular venous pressure rising on inspiration and falling blood pressure. In this case, the evidence suggests pericarditis and thrombolysis are not indicated. The ECG and enzymes should be followed, the patient re-examined regularly for signs of tamponade, and analgesics are given. A subsequent rise in antibody titers against the Coxsackie virus suggested viral pericarditis. Symptoms and ECG changes resolved in 4 to 5 days. An echocardiogram did not suggest any pericardial fluid and showed good left ventricular muscle function. The symptoms settled with rest and non-steroidal anti-inflammatory drugs. Now the last part: key points. Saint segment elevation, which is concave upwards, is characteristic of pericarditis. Viral pericarditis in young people is most often caused by Coxsackie viruses. Myocarditis may be associated with pericarditis, and muscle function should be assessed on echocardiogram and damage from creatine kinase and troponin measurements. Thank you for watching. I hope you like this video. And keep supporting AI Medical School.